One. We are live now.
Yeah, good evening, everybody, and welcome to this special webinar on high tibial osteotomy organized by Society of Knee Surgeons of India, SKI, in collaboration with APKS and Pune Knee Course, that's PKC. So, this topic which we have chosen is a very common topic, but somehow people are kind of moving away from the high tibial osteotomy, and that is the reason why we thought we should choose this topic, because it's such a wonderful operation and I think it needs more emphasis in today's time. So we are having three speakers today who will tell us about the tips and tricks of high tibial osteotomy. And before I hand it over to Bhushan, may I request Rajgopal sir to please say a few words about the ski and more importantly about his thoughts and ideas about high tibial osteotomy.
Thank you, Parag, and good evening. I think you summarized this in your introductory first two statements. It's a wonderful aiming to fall by the wayside. All I can say is in the young arthritic patient where the debate is between a biological solution and a mechanical solution, we seem to be choosing the mechanical solution in the form of unicompartment replacement. And while that has undoubtedly a defined role in the management of these patients, the role of the well-done osteotomy cannot be overemphasized. A lot of the times, because of the varus deformity, high tibial osteotomy is done well, will easily gain the patient 10, 15 years of very good functional outcomes. And be very interested to hear three very passionate osteotomy favored surgeons give us their presentations and their tips and tricks. So over to you, Bhushan.
Thank you very much. Let me start sharing my screen and let's see if we can see it. Okay. Okay, I hope you can see me. My name is Bhushan Sabnis, and we are going to talk a bit about HTO, its technique, tips, tricks, and traps. And those of who you know me know I'm quite passionate about osteotomy as a good surgery as such, and it really gives good result. So in simple words, HTO is a very good surgery when it's done properly for both parties. So for both surgeon as well as the patient, it really gives good results. So that's a standard way in which you see your HTO to be. You open it exactly where it wants to go, and your alignment comes perfectly, and it works really well. So the standard flow of HTO is you make a bone cut on the medial side, going to the lateral side to the fibula head, till the time you get a perfect alignment that you want, and then fix it with a plate. And it's an angle stable, fixed angle plate or a variable angle plate. And it generally gives you a good function. But there are a lot of things which can go wrong, and a badly done HTO is very bad. There are a lot of things that we are going to talk on about patient selection, investigations, deformity analysis, surgical planning, actual surgery, the process, proper rehabilitation. We won't go into great details about patient factors and a bit of luck to get your perfect results. So we are going to talk about tips, tricks, and traps for doing HTO and getting a good result. So the first and the foremost of importance is patient selection. I think I don't know whether it was Napoleon or anyone else, but it's a very famous quote. You always select your battles. So in the same way, I think patient selection is of paramount importance if you want to get the best possible result in your surgery. So if you're starting on doing osteotomy, don't select a patient like that. Select a patient only when you have metaphyseal varus deformity of the knee joint, and where the PFJ as well as the lateral compartment is well preserved. I'm sorry, that image should have flown out. Give me 1 second, I'm sorry. My fault entirely. So I'll just take this image out and then we'll try and show this again. Yeah, so you need to have a proper clinical assessment, gait assessment, look at the hip, foot, and other associated spine issues which can be contributing to it. Most important is the joint range of motion and to rule out any neurological issues. Always beware, this is a trap for most people. Patients demanding surgery, you need to be careful in especially high demand patients or patients who have abnormal expectations. There will be patients who want all the deformities in both the lower limbs corrected in one go. There are patients who will demand bilateral surgery despite not being fit for surgery. Smokers are one group of patients where I would be extra cautious, and I would at least advise them to stop smoking for 3 months. And even then also I'll be worried sick about the result that we are going to get. Stiff knees are absolutely a no-no, and do not decide surgery without a scanogram. So if you're going to struggle to find the knee, don't do the surgery. It's a simple opinion for osteotomy. So don't do surgery unless you are able to find where the knee and the tibia is. Now, the most important way in which you can decide on the surgery is a scanogram. And a scanogram is an investigation which unfortunately is easily done wrongly. And I'll show you a few examples how bad it can be to decide the type of surgery and the way in which you do surgery, just basically basing it on a bad scanogram. So you need to understand how to spot a poorly done scanogram. A calibration is a must unless you're ready to rely on angles and in degrees rather than millimeters of correction. And you need to correct the limb length discrepancy. So the keywords that you need to tell your radiographer when you send a patient for scanogram are patella facing forward and not the feet facing forward, with calibration with pelvic obliquity compensated or limb length discrepancy compensated with calibration. So you should tell your radiographer that these are the 4 basic prerequisites for getting a good scanogram done. This is a typical example of a badly done scanogram. So what's been done is that 3 different images are stitched together, but of course either the radiographer was drunk or was not paying attention. You can see it's a crap image. You can't make head or tail out of it. And if you start planning surgery on something like this, you're going to be in a big soup. This is a decent scanogram. You can see the patella is in the middle, patella are in the middle, but the pelvic obliquity is not compensated for. This again will not be a good scanogram. Similarly, this one, the pelvic obliquity is not compensated, so the radiographer should have put a block under the left leg to compensate for a mobile pelvic obliquity. This one is rotated maxillary. So if you look at the patellar shadows, especially on the left side, the patella is almost on the medial side of the joint. So it's not a right way of doing a scanogram. This, I think, is a decent scanogram. You can see the pelvis is level. You can see both the patella are in the middle, and you can see that drawing is done properly for the axis as well. I think this is the worst kind of scanogram that you can imagine. This is a lying down scanogram, and you can make out by the way in which the feet are placed. So this is a lying down scanogram, and never rely on a lying down scanogram for planning your surgery. One more advice is never to rely on the drawings of axis done by the radiographer. If you look at the axis marked on the right side, it doesn't make sense. It's going to the lateral side of the ankle joint, and this is something you should not rely on. This is one of the better scanograms I've seen despite the pelvic obliquity. If you look at the foot position here, you can see the foot is rotated significantly just to allow the patella to come bang in the middle. So only if this radiographer had corrected the pelvic obliquity as well, I would have given it 10 out of 10 marks and would have been very happy to plan the osteotomy. But unfortunately, there is only a finite number of times that you can send a patient for scanogram. So sometimes you have to rely on scanograms, and that is the reason that you also have to plan the surgery on table. So that is why you also have to make sure that your correction makes sense when you're doing the surgery on table. So my desktop looks something like this. There will be about, at the last count, there are about some 400 scanograms on my desktop. So the whole purpose of doing surgery is to get your alignment perfect and get your axis properly. So this is called as deformity analysis. On a properly done scanogram, you mark the center of the hip and center of your ankle, and the line joining these two is the weight bearing axis or the mechanical axis of the lower limb. And then you mark the joint line both on the tibial side and the femoral side. The angle between these two lines will be the JCLA, which is normally between 0 to 3 degrees. And then you mark this angle, which is the MPTA, and this angle, which is the LDFA. MLDFA stands for the mechanical lateral distal femoral angle. Both are around 87, 88 degrees. Anything less than 85 indicates metaphyseal varus on the tibia, and that is what we are concentrating on. Now, either depending on whether there is lengthening or shortening of that segment, you can decide on opening wedge or closing wedge. You can decide on a single or double osteotomy based on the kind of deformity you are faced with. And you can either do a paper planning or software planning. I think most of us have now moved to software planning, which makes sense. So a person will have a varus deformity or a valgus deformity. You measure the angle that is abnormal, and based on that, you decide whether you need to do an osteotomy on the tibial side or the femoral side as such. So diagnose where the deformity is. The old dictate that varus is tibia and valgus is femur is wrong. And if we get time, I'll show you a case according to that. So always plan your osteotomies. Again, failing to plan is planning to fail. So it's very important to plan your osteotomy properly, because that's a key to success or to your failure during the surgery. So this is roughly how I do my planning now. This is TraumaCAD software where you can decide about the angles. So if you look at the red ones, these are the wrong angles, and you can see they're almost corrected back to normal when you are planning your osteotomy. It's a double osteotomy you are planning for this patient. So you need to plan your osteotomies in such a way that you are able to get a straight joint line. Now this one was almost 13 millimeter correction, but you see the metaphyseal varus that has been corrected to a perfectly straight line. And this patient is quite happy with just a standard HTO rather than a double osteotomy, despite being severely deformed. So same thing again here. See the angles here. The problematic angles are changed. Both the LDFA and MPTA were abnormal, and both are corrected post a double osteotomy. And this patient went on to have a normal straight leg after double osteotomy as such. Now, a simple thing to remember whenever you're planning a surgery is to have sufficient equipment on standby. Now, the basic couple of things we are going to talk about as problems or traps during surgery is a hinge fracture, abnormal correction, or having any untoward happenings during surgery as such. So a few things that you need to have on standby is an assortment of plates and staples that can allow you to fix any hinge fracture or any progression of fracture line in any direction as such, a pointed reduction clamp, and locking plates for a lateral side. A T-plate on the lateral side is good enough. 4 or 4.5 millimeter cannulated screws are good enough, and a staple comes in handy, especially if you got a very slight, minimally displaced hinge as such. Now, incision can be entirely up to you. There are people who are still happy doing transverse or oblique incisions. Most of us have moved to a vertical incision because it's easier to incorporate in a future TKR. One word of caution: seeing senior accomplished surgeons doing osteotomy through small incision makes most of us start doing osteotomy through a very tiny cut. But that's again a recipe of disaster. I feel you should see what you're doing and not imagine what you're doing or feel what you're doing. So a cut like this, I think, is a difficult one to incorporate in a future TKR. So I would like to go for a standard longitudinal cut, just medial to the tibial tubercle or midway between the tibial tubercle and the posteromedial tibia. People have been doing a weird oblique cut, but this big an incision is generally not required. Now you need to release the MCL properly. I'll try and show a video at the end or in cases that will demonstrate what I'm talking about. But you need to release the MCL as much as required so that when you're opening the osteotomy, it's not stopping you from opening the osteotomy. If you don't release the MCL, you're surely going to get a hinge fracture, or you're surely going to get a fracture going in the joint as such. Something which I've been taught now and again and realized from my own mistakes is the slow and steady rule. You need to go very slow with opening the osteotomy. My ex-boss used to tell me, let the bone absorb the forces you're applying to, let it be a bit comfortable, and then you open that last millimeter. If you go a bit fast, you're going to end up causing more damage than help. And that's when you get a hinge fracture, which is very common when you're hurrying into opening an osteotomy as such. And if you're ever worried about whether your osteotomy is stable or not, that means whether you've got a hinge fracture or not, fix it. There's no harm done by putting an extra screw or a staple on the lateral side or a screw across the joint under the subchondral plate if you want to not worry about it later in the night when you can't sleep, or when the patient comes back in 4 weeks time and you see a displaced osteotomy or a fracture. So it's always better to fix it whenever you are in doubt. So much so there are a lot of surgeons who generally put a lateral screw just to fix a possible hinge fracture, which is also something which is cannot be criticized in any way as such. Slope change generally happens if your hinge goes, or if you're not careful to create a trapezoidal gap. So a simple way is to keep two parallel K-wires, proximal and distal, and make sure that they are still parallel at the end of it. So try and keep it simple, and that will help. Let's talk a bit about hinge fracture, because that is something which is commonly discussed or commonly asked and commonly not answered properly. So this is something which I like to talk a bit more about. Of course, we all know Takeuchi's classification for various types of hinge fracture. If you look at the proximal tibia, the lateral side is well supported by the lateral tibiofibular joint, which is actually creating a good support cushion on the lateral side. So any fracture which goes in the lateral tibiofibular joint will still be stable, because there are ligaments proximal and distal, and they will still hold the osteotomy really well. So type 1, I won't worry too much. Type 2 is when the fracture line goes distally. And now this happens when your osteotomy is very low. So rather than aiming for the fibula head, you aim for 1.5 centimeters from the lateral joint line on the tibia, and this problem can be minimized. And type 3 is when the osteotomy extends into the joint. This is the disaster. If you don't look at it properly, you're bound to get a lot of problems. So type 1 is the most common, and I feel most of our patients actually will have a type 1 fracture if you look at a CT scan done immediately. Type 2 is very unstable, and that needs to be looked after very carefully. But if you have an angle stable plate with hinge compression, you might get away with it just by offloading the osteotomy and not allowing the patient to walk for some time. Type 3 is unstable as well as devastating. The moment the patient starts weight bearing, the joint is going to collapse and you're going to be in a soup. Again, it's important to know where to create your hinge. So this black circle is the ideal area where you can hinge. You can create your hinge. Too proximal, you can go in the joint, or you can come out on the lateral side of the tibia. Too low, and you're going to get type 2 fracture. So this is the area which you try to hit every time when you're putting your K-wire in to create a proper osteotomy. How do you identify whether you're getting a hinge fracture? Of course, you can always hear a sound or a snap when your assistant tends to help you too much by trying to open the osteotomy suddenly. If your osteotomy suddenly starts opening very easily, then it's sure short understanding of the problem is that it's a hinge fracture. If the distal fragment starts displacing, that's again an indicator that it's the osteotomy has become unstable and the hinge is cracked. Post-operatively, you can always assess this by displacement or significant increase in slope, or if there is callus formation on the lateral side. But mostly the patient will come with either overcorrection or significant pain on the lateral side of the knee. Unstable osteotomy, if not managed properly, will lead to a delayed union or non-union. And if you see a suddenly increased slope in your post-op X-ray, you need to be worried that this is an unstable osteotomy as such. So this is roughly where I normally try. This is roughly where I normally try and come for my hinge. So my hinge will be somewhere here at this spot, and that will make my osteotomy not open up. A couple of examples. You're opening it very nicely. You still have left a good amount of cortex intact, but something is not right. And if you look carefully, there's something progressing here. You can, of course, fool yourself and say, this is my biplane, which is looking like this. But this is a hinge fracture which is progressing and going in that plane. Unless you look at it properly and treat it properly, you're going to have a big problem. Another example. So let me see. Yeah. So if you look at this line, that's the osteotomy progressing in the joint. So be careful whenever you're opening the osteotomy. If it becomes too easy, just put a screw across and you stop worrying about it, because the osteotomy becomes super stable just by 1 or maximum 2 compression screws coming from lateral to medial side. So this is, of course, pretty obvious where you haven't cut the distal part properly. You haven't cut the distal osteotomy properly and just opened it too fast, and you get a fracture line propagating. You just need to fix it with a screw. something like this, and then the patient will not even realize that there was a fracture. Funnily enough, if you fix it, the patients have no pain and they're absolutely very comfortable, even in the post-op phase, even if you weight bear them. But generally, I weight bear them later by about 4 to 6 weeks from surgery. If you don't find it, or if you don't realize you've had a hinge propagation or hinge crack or osteotomy propagation, you're in a soup, because then you'll start getting subluxation where the proximal fragments start displacing medially or the distal fragment starts displacing laterally, and you get invariably a plate breakage, and that's a disaster generally. So you need to be extra cautious. The moment you see it, you take the patient back to theater, refix it medially as well as laterally. How to manage proper hinge fracture is be vigilant about it and fix it as and when required. So if it's a type 2, it's unstable, you can put a small plate, angle stable plate on the lateral side. That is a sufficient precaution in most cases. If you have a staple on the side, you can even put a couple of staples on the lateral side, and they do heal, though very slowly, but it will heal and weight bear them later, and that should work really well. If you have a hinge fracture, mainly type 1, you can still get away with a system such as a Tomofix plate or any angle stable fixation system with a T plate in T plate fashion, where you can put the D screw to compress the hinge, and that will usually allow the hinge to be sufficiently compressed without worrying too much about problems. But if you see something like this happening when you're doing the surgery, always put a small plate. So this is actually the epiphysiodesis plate that can be used as well. If you find it late, let's say you've opened the osteotomy, you've fixed it, you're happy with your fixation, but you get an X-ray post-op and see a type 2 hinge fracture, you fix it with a plate on the lateral side, and that usually leads to good healing of your hinge fracture. This is generally how I check my osteotomies on table. There is live screening going on, and I'm trying to open and close the osteotomy. When you're done sufficient MCL release, you will be able to open and close the osteotomy really easily and confirm that your lateral hinge is intact. So as long as you don't go crazy and open it significantly suddenly, this is a very stable osteotomy. If you look at this spot, this is where the hinge point is, which is exactly at the area where it should be, just at the level of the head of the fibula, about 5 to 10 millimeters from the lateral cortex. And every time you do this, you are certain that your hinge will not break. Another easier way of managing this is putting a hinge protection pin. So you can see as you're opening and closing the osteotomy, the wire is bending. So that means the hinge is being protected actively by the wire, and that will stop the hinge from propagating laterally. And you can be one step ahead and take this wire off at the end and put a screw across, which is a simple 4 millimeter cannulated cancerous screw. I use it routinely for all my DFOs, but for HTOs also, it's not a problem if you put an extra screw on the lateral side, especially if you're using a new clip kind of plate, which is a smaller plate and which does not have a component of hinge compression as you would achieve on other plating systems. Now, a stupid plug-in of my own article, but important to know why the slope changes. Now we're talking about the slope. Now, if anybody is interested in why the slope changes, please have a look at this. I've tried to explain it really well. The proximal tibia is a triangular shaped bone. And if you measure the bone cut here and bone cut here, it will never be the same. If it's the same, that means you're increasing the slope significantly. That is, of course, anterior, that is posterior. So if you are measuring the bone opening on the front and the back in a normal 45 degrees angle tibia, it should be at least twice on the posterior side as compared to anterior side. Since we do a biplanar osteotomy, it's about 60% more on the posterior side as compared to anterior side. So that's the key in which you open the osteotomy in such a way that you create a trapezoidal gap. And when you make a trapezoidal gap, the slope generally remains the same. So you can use your laminar spreaders, you can use your ready-made devices which are used to open the osteotomy, or you can use something like this where the K-wires are used, and on top of that you can use these instruments which are generally from the foot and ankle set, and try and distract the osteotomy in this way. Whichever works best for you, I think, is okay. most important thing to remember is to go slow and steady. Again, despite having a good scanogram and despite you being certain of good planning, it's always important to check your alignment on table. So find a center of hip, find a center of ankle, see where your correction is before the surgery to know the rotation, and then after the surgery till the time you are happy with it. I normally stay between the two tibial spine or just on the lateral tibial spine, depending on the severity of arthritis on the medial compartment. If it's grade 4, I normally go to about 60%. So I'm at the level of the lateral tibial spine. If it's grade 2 or 3, I stay between the two spines or between 50 and 55%. But generally, the olden concept of going to Fujisawa point, which is somewhere here, 67.5% is not a good idea. There is a misnomer about there's a misconception of Fujisawa point between 62.5, which is about here. I think 60% is the maximum I will go to and not beyond that. And on table, you assess the knee in full extension with a rod in under C-arm to confirm that you got the right protection as such. I already talked about lag screw and its effect on compressing the hinge. So it's important in the beginning of your career to use the lag screws as often as required. And if your plate position is slightly inferior, this oblique screw will go in the osteotomy that doesn't it just looks bad on the X-ray, but doesn't have any problems. So most of these X-rays are mine, except for some of the complications which I was fortunate of not getting, I've taken from various articles as such. Now, again, you can use various kinds of plate. We have talked about it. There are a lot of surgeons still using Puddu plate, which is absolutely fine, but a Puddu plate is unstable, especially if your hinge cracks. So you need to be extra cautious. So that whole D of Tomofix kind of system or a peak kind of system is very important to get the hinge compression. Whether you use bone graft or not is entirely up to you. I would support it with bone graft when the osteotomy opening is more than 12 millimeters. But other than that, I will be okay to do it without a bone graft also. A quick look at this scanogram shows the kind of plate bending you can achieve by using the compression screw through the first hole in the distal part of the plate. The plate will conform really nicely to the bone if you compress it nicely, and you can see the amount of bending that you can achieve in a small Tomofix plate, where you can actually compress the hinge significantly. And she's one of the happier patients after doing this surgery. Again, there are a lot of plate systems available. You can have the peak plate, which is again multi-directional screws for all of them, where it's easier to do any combined procedures. The new clip system is quite good as well. Tomofix, we have talked about, that's a sort of the gold standard. The biotech plates are also equally good now. I've tried them. So it depends on what you want to do. If you want to keep it simple, that will be ideal. But if you want to add something, if you want to do ACLR or a root repair, you can still achieve that as well. A couple of tips for doing a combined HTO plus ACLR is to do a distal biplane osteotomy rather than a proximal biplane osteotomy, for a simple reason that your ACL tunnel will have sufficient space. Quite a few times when you're combining ACL reconstruction and HTO, this part of the socket or tunnel will fall inside the proximal biplane. So a distal biplane with a screw coming here will be ideal. Again, I'm not a big proponent of all inside for most, but this will be a good indication to do an all inside ACL, making a socket rather than tunnel, where your bone stock will be preserved, especially where the biplane is, and you will not have problems of insufficient fixation of your ACL on the tibial side. Now, depending on what kind of reconstruction you're using, if you're doing an ACL reconstruction, it's better to move the plate more posterior so you have sufficient space anteriorly. And if you're doing a PCL reconstruction, it's better to push the plate proximally so that you have sufficient space for your tibial tunnel here. And indeed, I've done a couple of cases where I was distal to this whole D when I was doing my tibial tunnel, and there's nothing blocking my tibial tunnel in the PCL reconstruction. So you can be more adventurous and brave and do all these things as well. So again, slope change is something which is generally frowned upon, especially for patients who have poor ACL control. If you increase the slope, then you might need to compensate for that by doing a slope changing osteotomy. But an easier way when you're doing it is to break the hinge purposely, fix the tibial tubercle separately, and then achieve the slope that you want. I know this is slightly higher level, but works really well in most patients. But if you have someone with a PCL deficiency, they are very happy by when the slope is increased. So then you can achieve a rectangular gap rather than a trapezoidal gap, and the patients are generally happy with your HTO with a slightly increased slope as such. Now, rehabilitation is standard. Whether you want to weight bear them immediately or not is entirely up to you. I asked the patients to start weight bearing on the second day of surgery as tolerated. Most patients are partial weight bearing because of pain for 10 to 15 days, but after that they're walking more or less normally. I told you about a hinge fracture which can come later. So this is a patient of mine. This X-ray is about I think 6 weeks from surgery, and the reason I got a scanogram was he was having significant lateral pain, but during the surgery, I was 100% certain there was no crack. But you see this calcification happening here. That's the callus formation that is indicator of a type 2 hinge fracture. All I did was kept him non-weight bearing for 6 more weeks, and he became perfectly fine. A common question asked by patient is when can I start range of motion? Immediately, I don't stop them. And when can they start running? I said, try and avoid as far as possible. But after 6 months, if they want to start light jogging, that will be enough. So a very common trap given by the patient is that when can I go back to my sports activities? I think pre-operatively you need to discuss with the patient. Heavy impact activities will be difficult to do. So it's better you keep yourself to light activities and not promise them the heaven. Otherwise, they will put you in hell. I talked about a lot of other complications. We'll not go into details of neurovascular compromise. That's not common, fortunately. But a stiff knee is very common, and under and overcorrection are very common. This is fortunately not my patient, but someone who came to me with a massive overcorrection. You see, the Nicolaas point is something like 100 degrees, 100% from medial to lateral. So this patient is extremely unhappy. I ended up doing a closing wedge osteotomy for her on the left side to get the Nicolaas point bang in the middle. But these patients are generally very unhappy despite a second surgery. This is a standard CT scan that will show a type 2 hinge fracture. So if in doubt, treat them like a type 2 hinge fracture, or confirm that you have no hinge fracture by a CT scan. Again, a type 3 hinge fracture fixed with a screw and happy with the alignment now. There is no step off, and these patients generally do very well, as I said. One more question that patients will ask you and you'll be trapped into is the plate removal necessary? And in joke, we used to say that on a humorous level, we used to say that depends on the number of patients you're operating on that in that week. If you have not much of work, you can remove the plates. But what I feel is in younger patients, once the osteotomy is healed, I think it's better to remove the plate as an elective planned procedure 2 years or 1.5 to 2 years from the surgery, because then they can have a standard TKR done without worrying about using a TIBIAL stem. Word of caution, always have sufficient equipment on standby when you're removing the implants. There's a high chance of cold welding, and I think most of you know about me being sued by a patient for 5 crores for inability to remove a plate which was cold welded. So you need to be cautious about this. Patients are becoming slightly crazy and suing left, right, and center for weird things. So be careful about whenever you're removing a plate, have the Midas Rex on standby, have the conical screw removal jig or screw removal set on standby, and carbide drills on standby, because you never know when you will be screwed, unfortunately, as I was. So there are a lot of things which are wrong with this X-ray. This is my patient, so I own to it. But you see it's overcorrected. You see the screws are long. You see the bone is slightly osteoporotic. You see the slope is increased and the plate is not contoured at all. So that means I must have been sleeping when I put the screw D, because it's the first part, screw in the distal part, because the plate is not contoured at all. But funnily enough, this patient is very happy about it. So as long as your correction is between 50 to 65, patients are really happy. But beyond 65, if you go in this zone, which is about 65 to 100, patients are generally unhappy. So make sure you don't do these mistakes and try and get a perfect alignment as far as possible. Age has always been discussed as a criterion. This is a 75-year-old gentleman who had one side done and then had the other side done as well. And he's a retired justice. And you can see the correction you achieved and the way he's walking now. And within 6 months, he came for the other side as well. So I think good looking X-rays and happy patients correlate well. If you have X-ray like this. This is a colleague's wife who I did a staged bilateral HTOs 6 months apart, and she's perfectly straight and perfectly normal. The first thing that she was worried about is the leg length discrepancy, and I said I can guarantee up to 5 millimeters of leg length discrepancy. I was lucky enough to just get 1 millimeter difference. So patients are generally delighted and happy about it. So I have a whole series of staged bilateral HTOs done in quite a few patients, and the patients will come back to you to get the second set done when they're happy. Those of you who are keen-eyed will see that this is slightly overcorrected, but again, a distal biplane big correction generally tends to overcorrect slightly over time, and the patients are very happy. I suggest you all who are interested in osteotomy read these 3 basic things, which are very useful. Even if you're doing a knee replacement, also the Clement book is really good. So you need to follow all these things to get a good hang of osteotomies. I hope I've not bored you enough, and hope that made sense. If we get time, I'll show you a couple of cases, but it's now back to you, Ashok and Parag. Thank you.
Yeah, thanks, Bhushan. I think that was a very comprehensive talk and very wonderfully you covered the entire spectrum, right from pre-operative planning. And I was particularly happy because you spoke a little more about the hinge, which every one of us does have a problem, and I think you dealt with it very well. Any quick questions from the panel before we go on to the cases to be presented by Clement and Pankaj? So any questions, quick questions for him? So I have a quick question, Bhushan.
Yeah, Parag, I have a question.
Yeah. Rajgopal sir, you want
No,
to?
Parag, yeah, I wanted to ask a question to Bhushan.
Sure.
I'm not sure if I got this correct, but you said when you do an osteotomy, you do not use a bone graft in most of your cases. Did I get that right?
So I said I don't use bone graft for any correction under 10 millimeters. Any correction above 10 millimeters, I use a bone graft, and I use an allograft. So I'm fortunate in being in Mumbai next to Tata Hospital. So they're more than happy to give me a femoral head as and when I need it. So Tata
So Bhushan,
allograft for my patients.
Yeah, so Bhushan, this question may come out of complete ignorance. I'm not a trauma surgeon at all, so forgive me for the question. My understanding of healing of fractures in the cancellous part is by controlled collapse. 10 millimeters is almost 1 centimeter. How do you account for the fact that this gap fills up with a distracted plate holding that osteotomy open? This contravenes the fundamental sort of principles of cancellous bone healing. Can you just sort of enlighten me on that?
So we're going into more theoretical zones now. So I think if the only reason I would put bone graft in is to achieve 2 things. One is some mechanical stability for the osteotomy, and secondly, to have a tamponade effect. So I don't know if any of you agree with me or not, but when you put a bone graft in, the bleeding from the osteotomy reduces significantly. I don't think it promotes healing in any way. Though we tell patients that the collagen scaffold from the bone graft will stay just like that, the body will just eat the cells and the other stuff and build a new bone on top. But what you're talking about was controlled collapse. We are not achieving a controlled collapse here. We are opening the osteotomy and leaving it in that specific area. There is very minimal motion, micro motion that would happen in the osteotomy because it's a locked external fixator kind of position. So I think the healing will happen in the cancellous bone by the stem cells coming from the bone marrow up and down, and that will allow the healing to happen. The bone graft, allograft especially, I don't think has any role in healing of the osteotomy as such. It's only for some mechanical stability and tamponade effect that it can achieve. Hope that made sense.
Another fundamental difference what I find in when there's a fracture healing versus an osteotomy healing. Osteotomy is a very low trauma, minimal velocity kind of a opening of the fracture, whereas in of the osteotomy side, whereas in a traumatic fracture the mechanism is completely different. So that is the reason why I feel even up to 12 to 14 millimeters, Rajgopal sir, I have refrain from bone grafting. My magic number is 14 millimeters and more. Then I would bone graft it. So, and I haven't, to be very honest, had a problem for the fracture healing part of it. I've had my other share of complications. But Clement, do you have any comments on Rajgopal sir's question?
Yes, sir, I agree with you. Even up to 14 millimeters, I open without bone grafting. I think the healing takes place from 2 points. One is the lateral hinge point, where the bone starts forming there and slowly propagates medially to fill up the defect. And because we are doing a biplanar osteotomy, the anterior hinge, the broad hinge, also serves as a contact point, and the healing is reported to start from there also. So these 2 contact points are important for the healing to start and propagate further down. And probably it starts with a clot formation filling the defect, and slowly the callus formation invades that clot and resulting in formation of a callus bone later. So this is what I read, and probably I understood how the opening which osteotomy heals.
In fact, Professor Stobley in his paper and the AO manual recommends no bone graft to be used for up to 17 millimeters. So, Bhushan stops at 10. I think you've stopped at 14, but that is what Professor Stobley has mentioned as published work. And Bhushan, one minor correction, the quote, choose your own battles wisely, was by Sun Tzu in his famous book of War.
War. Yeah.
Your impressive collection of X-rays reminded me of another quote, don't confuse the map with the territory, by Albert Korzybski.
Okay, wonderful.
Great. So I just had a quick question. We'll have a quick answer because I think we're running out of time. We have very nice cases to be presented. You talked about the MCL release. And, when I do my osteotomies, I hardly do any MCL release, Bhushan. So am I doing something wrong, or because I don't touch the MCL? You spoke about releasing the MCL while doing a medial open.
There are 2 schools of thought essentially. So if your deformity is partially or fully correctable, then you don't need to release your MCL at all. That means the collapse is purely in the joint and the MCL is of its normal length. There's an older concept of MCL being contracted, which I think we don't agree about anymore. But if you are, as and when you're opening the osteotomy, if your MCL is taut, you will struggle to open the osteotomy and you are going to cause significantly increased pressure on the medial side, which might lead to a hinge crack, or which even might lead to significant medial pain in most patients post-operatively. So I think if you don't touch the deep MCL, you can almost fully release the superficial MCL without any instability in the knee joint. And I think one of the live surgeries I showed that I released the MCL completely from the TIBIAL side, not touching the deep MCL, and there is no laxity happening even in 20 degrees of flexion as such. So I know we all do joints and we talk exactly opposite when you're doing a TKR, when you're doing medial release. We don't touch the superficial MCL, we just release the deep MCL. But that is the main difference between an osteotomy and a TKR. I think MCL needs to be released. A tight MCL will be a harbinger of major problems.
Bhushan, how do you avoid injuring the deep MCL? Do you have any particular landmarks or any level beyond which you don't dissect?
If we get time, I'll try and show a small video. But normally I release the fascia along with the superficial MCL in an L-shaped manner. And the horizontal limb of the L comes about 1.5 centimeter from the joint line. So if you release it in an L-shaped manner, you're going to have sufficient space for the deep MCL, which will not be released. So that the MCL deep part will still be tethered to the tibia.
Okay, so let's move on to the cases. We have cases from Dr. Clement and Dr. Pankaj. And how many cases, Dr. Clement, do you have?
I have one, sir.
Okay, so we'll go with your case first, and then Dr. Pankaj, we can continue with you. And then Bhushan, if you wanted to show that video or some cases, we can finish by then. Yes, Dr. Clement.
So, good evening, everyone, and thanks for this wonderful opportunity, this webinar, to share this case. And we're going to discuss this patient who is a 44-year-old female and weighing 74 kg and 5'2" tall, presented with knee pain for 3 years, and it's been worse for the past 3 months. And before that, she was walking as an exercise 2 to 3 hours per day. Now she can't even stand for a short time. There was no night pain or wrist pain. The prominent clinical findings were the range of movement was full, very minimal patellofemoral tenderness, tracking was normal, no effusion. The medial joint line tenderness was mild, full extension of the knee was painful, the knee was stable. Okay. So now we go to the X-rays taken in 2021, 2 years ago. It shows a good medial lateral joint space. And this is the, I think this is a tunnel view or Rosenberg's view taken in a particular hospital. And this is a present one leg standing view, and these are the skyline views. And obviously in one leg standing view, you can see a joint space narrowing on the medial compartment. And this was the X-ray MRI taken 3 years back. And you can see there is a root tear posteriorly, but the meniscus is not extruded or maybe partially extruded here. And you can't see any bone marrow edema in this series of films here. You can see some kind of a mucoid degeneration in the ACL. I want to ask the panel, if you will see the patient in this stage 3 years ago, so what would be your advice for the patient? What is the prognosis of the lesion? And what kind of treatment would you do?
So let's start with Raju. Your thoughts, like, so you have 3 years ago first, you want to know, when the patient had just the onset of symptoms with varus deformity.
Yeah, with
And
this
the patient did
MRI.
not have a root tear at that point of time.
Yeah.
I would have advised her to work on weight and do exercise and maybe given either a steroid or a visco supplement to manage the pain. That would have been my approach, would have been a conservative approach back then.
Even the root tear?
Yes, so I have only recently started repairing the roots a lot. But yes, back then, your question is what would I have done 3-4 years ago? Probably not have repaired the root back then.
Okay. And you can also see the medial femoral condyle showing some subcondylar cystic changes here. Would that be a concern for you in your decision making? That this shows some early signs of overloading and stress in the medial compartment?
Yes, it would be, and I would properly counsel her to get a scanogram. I will initiate the conversation about realignment procedure, but then to be very honest, my approach would be a bit more conservative.
Okay. Pankaj, any thoughts? Just unmute.
Sorry. So I would like to do an orthoscanogram for this patient and would definitely check her alignment at this stage. And then, of course, counsel her about the possibility of doing some surgical intervention if my alignment is not right, if there's a mechanical axis deviation which is significant, and then consider doing something for the root at that stage. But yes, scanogram is a must at this stage for me.
So we'll go to the present MRI, and this is how it is looking. And you can see the meniscus is completely extruded, and you also have a severe bone marrow lesion on the medial femoral condyle as well as bone marrow lesion on the edge of the medial tibial condyle, and you can see on the sagittal sections as well. And here you can also see the ACL is a mucoid degeneration, and these are some of films. The axial sections reveal reasonable patellofemoral joint, you can see here. So here, how would you correlate the present symptoms with these lesions? Is the mucoid degeneration to be considered seriously addressed, or you would address root tear? I mean, there are multiple lesions here. How each one of them is going to affect the
Bhushan, any
patient?
thoughts on this, Bhushan?
So I think 3 years back, she was having a failing medial compartment. Now she's got a failed medial compartment. So the medial side is completely gone. Now it's become bald. There's significant edema on the medial side. The meniscus is non-existent. ACL mucoid degeneration is I think not that important unless she's having significant pain in knee flexion, which can be sorted just by injection, or when you're doing arthroscopy, you can just trim the mucoid degeneration. But I think she should have had a HTO 3 years back, but now also, if she's less than 50, the lateral side seems decent. The PFJ is slightly iffy, I agree. So she can still have a realignment based on the scanogram properly planned. And possibly, if you feel she can have something done about the cartilage on the medial side, like a BMAC or microfracture. I don't do microfracture anymore, but something like that. But I think she will need a HTO, or should have had HTO long back.
Okay. Would anybody suggest a unicondylar knee even at this age, 44, with this amount of lesions?
Well,
is there any contraindication to do a unicondylar knee in this patient?
There's no classical bone on any of your x-rays really. So I think that is something which would stop me from doing a uni at this point of time. Because
so let's go to the next slide. Once again, same lesions seen in different sections. So here we have a situation of chronic symptoms. There is a possible cartilage injury, severe bone stress edema, and we have to consider whether the unloading the joint should be okay. So we got a proper scanogram here with the magnification marker here. And here you can see the weight bearing line on the left side, which is falling 10 millimeters from the medial, from the center of the joint. Bhushan, here the alignment looks reasonably okay. Would you still consider doing any HTO for this patient, or you will do
as
only
we discussed last weekend, Clement, I think even a 5 to 7 millimeters opening osteotomy also makes a lot of difference. So if you are able to bring the Nicolaas point to about 60% in her, she'll be very happy. Because not only will you be releasing the MCL to open the medial joint, but you're also shifting the weight bearing axis laterally, which is a good compartment for her. So she should be quite happy by an osteotomy, I feel. The only issue will be the PFJ, because the PFJ will not like that. So we'll talk about that as an
clinically, the PFJ was very mild, as I mentioned in the first few slides. So the patellofemoral pain was not there. In fact, most of the pain came in full extension. Possibly the ACL mucoid is also giving rise to this kind of a mechanical symptoms. When there is a full extension, was very painful in this patient. So this is a software simulation of osteotomy. So you can calculate how much of wedge you can take. A minimal wedge correction itself resulted in shifting the weight bearing line to beyond lateral tibial spine in this patient. So this was the orthoscopic picture here. There's the status of the medial femoral condyle. There is a complete root tear, and also the medial trochlea is totally devoid of any cartilage, but still she was not having that much pain. So we did a radiofrequency chondroplasty for the medial femoral condyle, and the medial trochlear lesion, we did a thorough debridement and burring to remove the calcified layer. And then we went on to do a root repair in this patient. So you can see it's a 3-year-old injury. Still, the quality of root was pretty good. So even the medial tibial cartilage was good. So we went ahead and did a root repair in this patient. So usually I pass the sutures first, take 0 fiber wire, then relay it with the number 2 fiber wires. So 2 to 3 sutures is being put in the root region. And I always use a 0 fiber to pass initially, so it will be less traumatic to the meniscal tissue. And once we pass all the sutures, the footprint is marked, and you can drill the tunnels like this. And then we went on to do an open orthotomy, where the medial trochlear lesion was repaired with the BMAC clot, with thrombin and fibrinogen. And she also underwent high tibial opening with osteotomy, minimal correction. And this is a result after 3 months. She had very good pain relief, because I was very much worried that with so much of conditions, whether any surgery would give complete pain relief. But this is the power of osteotomy, where it gives very good results. And in many patients where we have done root repair in obesity as well as slight malalignment, and we have seen the root repairs to fail, especially if the patient is young, symptomatic. You do a root repair, you always try to think whether HTO should be done to protect it, because definitely it has got a protective value when you do a root repair. And we have to re-emphasize that proper biomechanics is a basic for biological healing. And when you're dealing with cartilage lesions, even a slight correction of 2 to 3 degree varus also gives enormous clinical relief. So with this, I think I'll stop my case.
Just a quick question. Did you do anything for the meniscus extrusion, which you said the medial? Did you do any release incisions or something to correct the extrusion?
No, sir, I don't do any release. Here, it was easily, it can be brought back to its footprint. And I don't do centralization suture in my patients. And probably when you're doing osteotomy, I think you can skip the centralization suture. But the important thing is the root has to be brought to the anatomical footprint. So you have to spend considerable time and focus in defining the insertion of the root. And then bringing your tunnel exactly into that point. Then place 2 to 3 sutures, the posterior root, and then you can really reduce the meniscus. I have not done any centralization so far.
Clement, what is your opinion on the emerging literature which says that probably in a situation like this, a root repair can be omitted because both will just result in a 25% reduction or an increase in load transmission? Like repairing a meniscal root medial meniscus would result in a 25%, 1/4 reduction in load transmission, the same achieved by a high tibial osteotomy. So a lot of literature coming in from South Korea, which says that you get the same results, whether you repair the root or whether you don't repair the root.
No, when you do repair of the root in these patients, definitely without osteotomy also, they do very well for a few years. And when you do osteotomy without repair also, they have improvement. So in my opinion, if you add these two things, it is of additive value. I think if you skip doing these things for the ease, we won't have the tenacity to do the right things. You may become lazy. So you have to always, try to do these things so that you don't hesitate from doing that. So usually the root repair, once you start doing it, takes 10 minutes of your time. And there are ways you can combine HTO with your root repair. So once you keep on doing that, you will have the courage to do that. I think if you stop doing that, then your even a routine root repair will become easy. So in my opinion, these two procedures can have additive value. It may fail also, but I think we don't cause any more trouble or any more complication by adding a root repair to HTO. That's my personal take.
So just a theoretical question, Clement. So if you were supposed to choose one procedure, like Raju was saying, you can skip the repair, and you were to choose between just a repair or an osteotomy for a situation which you just showed us, what would be your choice of surgery?
What osteotomy? Osteotomy without cartilage repair, without root repair would have given very good improvement. But I think
the other way around, if you just do a medial meniscus root repair in a degenerative knee and skip the osteotomy, then that, in your opinion, it doesn't last long?
Yes, sir. We have had failures like this where we have to go back to convert them into TKR also. There are two situations where I would do an isolated root repair. One is a very young patient, recent onset, good quality tissues, not much of extrusion, and very minimal malalignment, almost near the medial tibial spine. Then we'll do that. The second group of patient is above 60, where you don't want to do osteotomy, do a major surgery, and result in an unhappy patient. Once again, this elderly group of patients, the subset, once again, I choose them based on the onset of pain. If it is 2 to 3 months, we can expect a good tissue. And you have to do a liberal pike resting so that the medial compartment is opened up. And usually I protect these elderly patients' repair with 3 to 4 months of offloading brace. Whenever they are expected to walk more than 5 minutes, I ask them to wear this simple offloading brace. That gives an H2O-like effect until the meniscus heals nicely, which may take more than 6 months, in my opinion. So these are the two groups of patients where I do an isolated meniscal repair.
Bhushan, any quick comments before you go to Dr. Pankaj's case?
So I've also read the literature from South Korea where they say there's not much of difference in repairing a root, chronic root, especially with HTO. And I tend to decide based on a patient basis. So if someone has a really poor quality tissue, then trying to take a stitch through it is more of a hassle and more of a headache for patient as well as you. So I'll be more selective in my root repairs. Whenever I'm doing a good HTO where my correction is more than 7 or 8 millimeters, I'm tilting the joint significantly to the lateral side. There'll be less weight coming from the medial side, and these patients don't need a root repair, ideally speaking. So a smaller correction, acute root tear, good quality tissue, slightly younger patient, go for root repair as well as HTO, in my opinion.
So would you just do some trimming of the root, because sometimes it causes mechanical symptoms, you know, it causes
If
clicking.
the root is flapping about in the air, then I'll just trim it off. I agree.
Because in some cases I have seen where I did a repair, only a repair. In fact, the patient post-operatively worsened in some of the cases. So, you know, then I was in a dilemma because, of course, the meniscus was extruded. I don't know, you know, I could not correct it fully, whether that was the reason or, you know, something else was the reason. But the patient had more pain than before after the repair. So
I think if you do a liberal pie-casting of the MCL, then the meniscus does tend to go in a bit more easily.
okay.
And with these root repair anchors, probably the vexing problem of putting the screw at the right angle is also obviated. I mean, you can use a root repair anchor and easily combine, but the real question is it worth it? Probably, I think Bhushan's approach is a better one, which I intend to take.
Just one technical tip. What I do, Clement, use the stitches, you know, I try to orient them at right angles to the meniscus than what you showed. So when you pull it through the tunnel which is made, you know, the root tends to go in. So rather than just keeping them straight, I orient them in the axis of the meniscus, turn them and then pull it down.
Okay.
So may I ask if anyone of you can throw a light? There are some patients where we do high tibial osteotomy and they have impinging medial osteophytes also. So is there anything which we can do about those osteophytes, or rather should we do anything about them while doing HTO?
To me?
Yeah, Clement.
Yeah. So when you do this STOs, we routinely do scopies. We do a lot of this bony osteophyte management. One is that anvil osteophyte. You look in front of the ACL, that will be removed usually. And second thing is you look around the notch. If the notch is very narrow and we have notch osteophytes, we tend to do a liberal arthroplasty and remove all the notch osteophytes. That may reduce the pain that can occur due to the ACL getting impinged by the notch osteophytes. Then usually I also look at the medial femoral condylar margin. If there are any osteophytes, we usually take burr or a scoop to curate out the osteophytes. I think by combining these osteophyte removals can improve your pain in the osteotomy. That's my personal thing. So routinely we do scopy, we remove all the osteophytes from everywhere. Bhushan, you do the same thing?
So, something funny which I normally have found is that if you use these osteophytes as bone graft, for some reason the osteotomy heals very fast, believe me. So when you have a big osteophyte on the MFC or MTP on the medial side, through the same incision, you just use a small ronger or a small nibbler and take those osteophytes off. Don't release the deep MCL, of course, and use those osteophytes as a bone graft, and you'll be surprised how quickly the osteotomy heals. There's something biomechanically weird happening in these osteophytes. So they are very good bone graft substitutes.
Dr. Bhushan, could you just tell us how do you remove the medial tibial osteophyte? That's what I was asking actually.
So when through the same incision, your MCL is in the posterior 1/3 of the joint. So it's not in the anterior 2/3. So you have access to the anterior tibia. So you might want to extend your incision slightly proximally and take the MTP osteophyte off. That anyway detensions your MCL, and you can do it before you release the MCL distally, because you might be surprised when you detension the MCL, you may not need to release MCL completely. You can get away with, let's say, 50-60% of release only. Is the MFC osteophyte which are slightly tricky, and you might have to go intracapsular for that. But generally the MTP ones are more significant for tensioning the MCL.
Yes, thank you so much.
Okay. So let's go to the next case, Dr. Pankaj.
Yes, sir. Please allow me, sir. I'll be also mixing it up with some messages for the audience.
Sure, that's what we want.
Yes, thank you so much for that. So as we've heard about the planning of the osteotomy and also how to mix and match along with the arthroscopic procedures. So here are a few case-based messages for good execution of the plan which you have done. So actually what we are doing in the osteotomy, we are bringing the actual anatomical center of the ankle in a deformed limb to a planned virtual center. So main concerns with the osteotomy are overcorrection versus undercorrection, too short a osteotomy or a longer osteotomy, too low versus too high, hinge fractures, and hinge fractures leading to non-union or delayed union. These three have been dealt by Dr. Bhushan already. So I'll be focusing more on overcorrection versus undercorrection and slope issues. Why do we say that open more posteriorly than anteriorly for getting a good correction? We are aware of this Herney-Goose table wherein we can plan how much opening we should done on the medial side, which is based on the width of the proximal tibia. As in this case, we can see that for a width which is here of 50 millimeters, for achieving a 10 degree of correction, we have to open 9 millimeters. While for a 65 mm proximal tibia width, it is 11 mm for the 10 degree correction. And this width is measured by the length of the K wire, which we have put up to the hinge point. So on the table also, you can measure the length of the K wire and then refer to this table. But how does the problem happen? Now, if your osteotomy is shorter than planned, then of course, your osteotomy opening will be less, although you are seeing the same angle of correction through your osteotomy spreader. So let me explain how. If we see these three situations, then for the same 20 degree angle opening, if my hinge point shifts medially as it is going from above below, then if my osteotomy is short, then I'm opening actually less amount of bone on the medial side and achieving smaller correction. So we have to make sure that when the osteotomy spreader is put in, if you use that, then it should reach up to the planned hinge point, which you did in the preoperative planning. So not reaching the planned hinge point is the first problem, which is completely avoidable and it prevents undercorrection. As you can see here, if your osteotomy is short, then it is not only the undercorrection, you're more predisposed to get hinge fractures also. Dr. Bhushan talked about it. And although the message is that if you use an implant which can compress the lateral hinge, then actually you can deal with these situations better. More so in Takeuchi type 1, you always put a golden screw which compresses the lateral hinge, because there are so many patients where on the C-arm you're not able to make out whether you have a lateral hinge fracture or not, and it may surprise you in the post-operative X-ray. So it is always good to use an implant which can compress the lateral hinge, especially if you are doing a single procedure and not combined procedures. And for you, it is a tip that when you have put two wires where you are going to do the osteotomy, always try to run your saw into the wires. Try to cut the wires so that you're not going too low. So, and don't be afraid going close to the lateral cortex, because believe me, if the osteotomy is shorter, then the chances of landing up with a type 2 or a type 3 fracture are higher, which are very, very difficult to manage. So let me show this case. This patient had a significant medial deviation of the mechanical axis. And as we can see, the LDFA is normal, while the MPTA is 80.9 degree on the right side, which is also the symptomatic side. So when you put your wires, you have to make sure that, as you see in the first picture, you can see two lines on the medial tibial plateau. You have to ensure that you see a single line, and then both the K wires which you have put are superimposing and they're parallel to each other. Then if you do that, your slope correction, your chances of changing the slope are minimal. And you can also use this hinge wire, which is very, very useful, and we use it routinely. And when you put this hinge wire, the opening, if you're opening especially more than 10-12 millimeters, then it protects the lateral hinge from breaking and also prevents change in the slope. So in the same breath, let me also talk about the slope management. And increase in the posterior slope is very, very common in opening wedge osteotomies, which are not well planned or not well executed. And we already talked about it, that your opening in the front, that is in the anterior side, should be less than the posterior. And releasing the superficial MCL liberally in the initial few cases is a very good idea, because otherwise you end up opening equally, and which can change the slope. So number 6 is for slope neutral correction, anterior should open less than the posterior. There are multiple papers, landmark papers, which you can refer to and get an understanding of it. So let me also briefly explain why this happens. See, this is a coronal plane, this is the sagittal plane, while we are doing the correction in a third plane in a triangular bone. So when we do that, it is bound to change angles in both the planes. So how do we actually execute it? When you put your wires for the osteotomy, you should see the articular surface as one thin line, and you should also make sure that both the wires superimpose each other. How does it help? If you see in this picture, if your K wires are parallel in the coronal image, in the AP image, and the tibial plateau is also flat, then your wires are actually going parallel to the slope, the native slope of the patient. And then you go in and execute this, that the posterior should open more than anterior. And there are 3 landmark papers on it. I've referred to them. So to understand, if your anterior posterior dimension is 1:2, your slope neutral. If it is 1:1, your slope has increased. While if it is 1:3, then the slope has decreased. So here are the pictures which we do in routine osteotomies. You can see in the first picture, it is 11 millimeter, which is the posterior opening, while on the other picture, it is 8 millimeter, which is the anterior opening. And number 9 is early weight bearing. If you have kept the hinge intact and used a rigid implant, solid implant like Tomofix, then early weight bearing actually has shown to increase the bone healing. Other problem is overcorrection, and which typically happens if you see this patient's gait. She's walking with a significant varus thrust, and she's a young 46-year-old lady. And this varus thrust, whenever you see, you should always think in your mind whether we have some deformity in the femur, even in a varus knee. So if you see this patient, there is a significant mechanical axis deviation. And if we see the angles, besides the MPTA, the LDFA is also increased, which is 92.1 degrees. So we did the planning for double level osteotomy on TraumaCAD, and I'm just showing some Shyam images. These are the wires put for the distal femoral osteotomy, which is lateral closing wedge. And even after fixing, correcting on the femoral side, you can see the alignment rod is running on the medial side. And then you go ahead and do the correction on the tibia, and that reduces the magnitude of correction which you have to do on both the bones. And hinge should be kept intact, as you can see in both the videos, that the osteotomy can be compressed on the femur while hinge is intact, while it can be opened on the tibia with that springy effect, which tells you that the hinge is intact. And you go ahead and fix both the osteotomies. And this is the patient doing open gym activities at 6 weeks after the surgery. So point number 10 is don't try to correct everything in one bone. Have high suspicion for having some problem in the femur also, even in varus knees. I thank you very much.
Thank you. Those are very good tips, Pankaj. Any comments? Anybody has any more cases to present? Or then we can just have discussion for a few minutes and close the session.
So I'd like to start by asking Pankaj, a very
Sure.
nice case for double level osteotomy, but you would agree, Pankaj, double level osteotomy is not every surgeon's cake and every patient's cake. So it's difficult for both parties. What is the upper level of MPTA that you are willing to accept in a high tibial osteotomy to say that, okay, I can probably get away by not doing a double level osteotomy? That's my first question. And in your double level osteotomies, is it your usual preference to do the femur first and the tibia later, or it doesn't matter?
Okay, thank you for your question, Dr. Raju. So first of all, yes, if there is no varus thrust in a patient's knee, then even if there is some deformity in LDFA without varus thrust, we can correct up to 94 degrees if we're talking about the upper limit of the MPTA. But if the patient has varus thrust, definitely I'll make correction on both the bones. And as far as the sequence is concerned, then of course doing femur first gives me more freedom to reach where I want to reach, because femur is a closing wedge, and then I can open as much as desired to bring the alignment, the line of weight bearing to a desired point. So I do femur first and then tibia.
Right. And do you use a tourniquet during your surgery?
Yes, I do.
For both the femur and the tibia?
Yes.
Okay.
So usually my for this patient, we did a partial meniscectomy. Also, she had a small flat tear, and we could finish it in 100 minutes of tourniquet time. Of course, it's a teamwork and we are doing things in sync. Yes.
Yeah, so that's, I think, an important point to highlight. It is not something to be embarked on as a solo adventure, a double level osteotomy.
Yes, Bhushan, any thoughts on the question? Because what I would say is that if the deformity is in the tibia, you correct in the tibia, irrespective of whatever the angle may be. So,
Bhushan, you are muted, please.
So if you are looking at a deformity analysis, you can't create a new deformity to correct a present deformity. That's the main important thing to remember. So if your LDFA is just about 2 or 3 degrees more than your normal limit, I would stay on the tibia to correct the deformity. And I would add something more complex to the tibia like a TCVO. We have discussed about this in the past, where you can correct the tibial deformity more significantly. Unless there is a more than 5 millimeters closing or opening wedge osteotomy on the femur, I will try and avoid doing that. But again, it depends on your deformity analysis. If your angles are good, then I think you should not be creating a new deformity. And one more thing, one word of caution based on what Pankaj said. For patients who have varus thrust, that usually indicates lateral laxity as well. And when you're doing your deformity analysis, you have to subtract the JLCA from your intended correction. Otherwise, you end up getting a massive overcorrection in these patients. And they're never happy afterwards. So even if you get them to neutral, that should be enough for these patients, because the lateral side, there's a concept called hypomocleon. So when your weight-bearing axis tilts to the lateral side, there's always the lateral laxity is taken care of. So subtract your JLCA from your intended correction. Otherwise, you will get a significant overcorrection.
So, Bhushan, if the JLCA is subtracted, do you think one is leaning a bit more towards just a high tibial osteotomy, or still a combination of HTO and
I think when you start subtracting JLC, you realize quite a few patients you can get away with just the HTO. Pankaj is just rubbing his eyes saying, what am I saying here? But I think if someone JLC is, let's say 8, and your higher limit of acceptance is 3, so if you subtract 3 from 8, that's about 5, and you divide that by 2, so 2.5. If you reduce 2.5 from your intended correction, you might realize that you will be able to achieve the same correction just by
far less DLOs than what you originally intended if you subtract.
But once again, if you have deformity in the femur, correct in the femur also.
Well, it's a massive undertaking for both the patient and the surgeon. It's not an easy surgery for a solo artist to do.
Yeah, absolutely. I just started doing double level osteotomies in last 2 years more frequently, because my patients where I was overcorrecting on tibia, they were complaining about difficulty in walking because their ankle was not landing flat on the floor.
Yeah.
And that was
another question. What kind of assessment do you do at the foot end? Because a lot of these are seniors and they have the posterior tibial dysfunction with adult acquired flat foot. Does that play into your calculations while you're calculating all these angles?
Not in my case, because it is far away from the point of deformity. So not much difference in my planning. What about the other panelists?
I normally tell patients that it will take some time for them to settle with the foot. The foot deformity is generally compensatory unless someone has a acquired flat foot before they developed a medial compartment. Where if you're talking purely of knee sense, they will struggle in the beginning, especially if it's a big correction, to compensate for the corrected alignment. And a couple of patients have required injections in the foot, ultrasonic injections for pain on the medial side. So you need to warn them that they might suddenly realize that the ankle is looking weird and the walking becomes difficult, but within a few months it settles down.
Okay, any other burning questions? If not, I think we'll close this session. I think it was a very nice session with a very nice talk by Bhushan, covered almost the entire spectrum, followed by a very good case with a lot of learning points, what Clement presented. And that was really nice. And then Pankaj also gave some very good messages. I think ITBL osteotomy, there's so much more to it than, what was being done a decade ago, where closed wedge was so popular about 15 years ago when I did my MS in 1992. That was a time only of closed wedge osteotomies. And I still remember Dr. Lad, Dr. Dolakia, my father, used to do, closed wedge osteotomies. They never fixed it. Even if they fixed it, it was a 10-second fixation with the Coventry staple. And Dr. Dolakia never even fixed it. He just gave a cast. And, where have we come? 30 years down the line, 20 years down the line, the whole thing has completely changed. So I think it was a good learning, and things will keep evolving. And what we talk now, I don't know, 20 years later, what's going to happen. So anyway, on that note, thank you so much, Bhushan, for a lovely talk. Thanks, Clement, for that case. Pankaj, really appreciate your tips and tricks. And Raju, as usual, you're looking so dapper. Even at 10 in the night, when I'm just falling off, you're ready to go for a party, looks like.
Since I was not presenting a case, I thought I might as well compensate by overdressing.
Oh, come on. And thank you so much. Thanks, Clement. And Ashok, thanks for putting this together. We really appreciate Ashok's efforts. And thank OrthoTV for getting us on this platform. Thank you, everybody. Ashok, any concluding remarks?
No, I think it was fabulous and very concise. We could finish it in, say, 80 minutes. So, very good effort. Thanks, everyone.
Yes.
Thank you. Until the next webinar.
Yes.
Bye-bye.
Thank you.
Bye.